Hello, my name is Seyed Mohammad Hossein Tabatabaei from MGH Emergency Radiology, and I'm the corresponding author for this paper regarding pitfalls in interpretive application of artificial intelligence in radiology, a clinical perspective study recently published by AJR. I'm honored to present this work on behalf of our study team. Before diving into the paper, I'd like to provide a brief background. I did a research fellowship at UCLA as a member of an amazing research team led by Dr. Denise Averly, Dr. Ashley Prosper, and Dr. William Shu. And this great opportunity provided me with the skills to contribute to this current project. And I'm deeply grateful for all I learned from them. In this project, I had the pleasure of closely collaborating with Dr. Ghulam Reza Nejad, another outstanding researcher. I also wanted to thank Dr. Andrew Rosenkrantz, the AJR editor-in-chief, and all the reviewers. Their time and effort really strengthened our paper. Moving on to the actual paper, we know that AI tools for radiologic interpretation are increasingly adopted in clinical workflows and promise improved diagnostic accuracy, but also present some pitfalls. Successful deployment requires radiologists to understand these limitations. This presentation overviews common pitfalls in AI interpretation and offers strategies for developers to mitigate these issues. All presented cases are from FDA-approved AI software. In certain instances, AI models may show suboptimal performance due to coexistence of particular pathologies. For example, in an AI model for pulmonary embolus detection on CT pulmonary angiogram, accuracy may be suboptimal in regions that are affected by lung consolidation. These figures show a small non-obstructive pulmonary embolus which was missed by AI, probably due to the obscuring of vessel borders by adjacent airspace opacities. Many errors in interpretive AI products can largely be attributed to limitations in the training process, including biases related to the diversity, quantity, and quality of the training data. Improving model performance involves more than just broader training data. The model must also account for problematic cases and particular challenges relevant to the given interpretive task. As we know, radiologists learn to get familiar with the imaging manifestation of anatomic variants and age-related changes. AI must also recognize such patterns to avoid misinterpreting these findings as pathology. Examples of such findings include calcification of costal cartilage, age-related spine bone density loss, and prominence of cerebral sulci and ventricular system. This figure shows a patient where AI misclassified a calcification on the anterior falx cerebri as a hemorrhage. This error could have been potentially prevented through more diverse training data that would have educated the AI algorithm to recognize age-related changes. This figure shows a patient with a post-traumatic T2 compression fracture. The patient has concomitant spondylosis, and AI failed to identify the fracture. As we can see, there is loss of approximately 50% of anterior vertebral body height with intact posterior border. But the presence of osteophytes at the anteroinferior aspect of the fractured vertebral body likely contributed to this vertebral body's anterior border appearing potentially similar in size to posterior border. So this could cause a misinterpretation of vertebral body dimensions. Post-operative changes can also impact image interpretation. This figure shows a patient with a post-craniectomy subdural hygroma where AI interpreted post-operative dural thickening as intracranial hemorrhage. Axial image from 8 months earlier shows similar appearance of the finding, which is another evidence that a human radiologist uses to confirm that this is not a hemorrhage. Other examples of post-operative alterations that may affect AI tools' accuracy include surgeries that alter anatomy, for example, craniectomy or laminectomy, or presence of surgical clips or other instruments. The performance of AI algorithm can also be affected by the presence of medical devices such as catheters, implants, prosthetics, or pacemakers. These devices may either cause artifacts or distortions, obscure anatomic structure or pathologies, or may themselves be misinterpreted as abnormality. These figures show a patient where AI mistakenly identified a ventriculopleural shunt as rib fracture. The hyperattenuating catheter curved adjacent to a rib mimics rib fracture. So models should be trained on images that contain such devices. The incorporation of scout images can also improve model accuracy, because a scout image provides a comprehensive view of the body that may help in medical device identification and localization. Presence of image artifacts can also be a potential source of inaccurate AI interpretation. These figures show a patient where AI misinterpreted this beam hardening artifact as intracranial hemorrhage. As we can see on the heat map, this area is primary area of concern for AI assessment. Repeated exam didn't show the finding that was identified on initial CT. Also, motion artifact could be a cause of false negative AI result for detection of intracranial hemorrhage. These figures show a patient where motion artifact resulted in irregular hyperattenuating foci in the skull base, causing AI to miss a hemorrhage in the pons. Historically, the presence of motion artifact has been a common exclusion criterion for image selection within AI training sets, so the developed models couldn't sufficiently account for this artifact. As we know, comparison with prior images is a key aspect of radiologic interpretation. AI models may learn only to interpret a single exam without considering relevant other images. This limitation in model development can lead to diagnostic errors. AI models may be trained to integrate prior and concurrent imaging exams, and what I mean by concurrent imaging is inclusion of different modalities from the same time. This figure shows a patient where AI interpreted a colloid cyst of third ventricle as hemorrhage. This figure shows another patient where AI misinterpreted a parafalcian meningioma as hemorrhage. In both cases, subsequent human review of a prior CT showed the long-term stability of these findings, and it was critical in determining the correct diagnosis and showing the AI misinterpretation. Potentially, AI could learn to similarly compare findings with earlier exams. These figures show a patient where AI detected restricted diffusion in the right thalamus and opercular cortex on brain MR, but missed the occlusion of M2 segment of right MCA on later 3D CT angiogram. This error could potentially have been avoided through integration of knowledge of the DWI finding into the AI model for CT angiogram analysis. Of course, in addition to targeted fine-tuning of the large vessel occlusion detection algorithm itself. AI models could receive inputs not limited to radiologic images, but additional relevant clinical data. For example, many factors such as age and BMI have predictive role in osteoporosis risk. This figure shows a patient where AI failed to detect a hyperextension type lumbar spine fracture. This error may have been caused by the presence of diffuse osteopenia and the absence of wedging or vertebral body height loss. An understanding of the trauma mechanism by AI tool may have assisted fracture identification. Specifically, age is an important model input, given its strong association with a wide range of pathologies. By integration of prior imaging exam and relevant clinical information, AI tools may learn to provide a holistic interpretation of the patient's pathology, similar to a human radiologist assessment. We have seen cases where AI initially detected a finding such as a fracture, but failed to detect the same finding on a subsequent imaging of the same or different modality, even though the appearance of the finding remained the same. Such cases highlight how contextual information beyond the image itself can affect AI interpretation. The satisfaction of search effect is a well-known phenomenon in radiology, where additional abnormality is not detected after an initial abnormality has already been identified. These figures show a patient where AI algorithm failed to identify a second hemorrhage after successfully detecting an initial hemorrhage. So AI algorithm must be developed to continue to scan each image even after detecting an initial pathology. Explainable AI techniques make the process of AI decision-making more clear to radiologists. Heat maps are a common explainable AI technique used in the context of interpretive AI and can sometimes help radiologists discover source of AI errors. These figures show a lumbar spine CT where AI mistakenly marked the majority of the vertebrae as fractured. The heat map indicates the portion of spine on which the AI model focused to reach this decision. This information provided the radiologist with insight into the algorithm decision that wouldn't have been apparent from the positive AI result alone. This emphasizes the fact that AI developers should merge explainable AI techniques into their model and create models that effectively communicate their image analysis process. Successful AI deployment requires collaboration between developers and radiologists to understand and address model limitations. Radiologists should actively provide feedback on AI performance to help refine models and improve accuracy. Close communication enables both groups to exchange expertise and fill the gap between clinical needs and algorithm capabilities. Thank you for your attention, and please email me if you have any question about this presentation or the paper.